بسم الله الرحمن الرحيم. We are going to discuss together an overview about peripheral neuropathy. By definition, any abnormality regarding the peripheral nerves or the cranial nerves is considered neuropathy. So whatever the pathology, clinically it's going to be called neuropathy. By the end of this lecture, I will need you to understand how to reach a diagnosis of neuropathy. I mean full diagnosis. يعني بنهاية المحاضرة عايز نقدر نوصل في النهاية ان انا اعمل comprehensive diagnosis of neuropathy, including it's a lower motor neuron lesion, which as we know له many steps من الانتير هورن سيل لغاية الماينيورال جانكشن. سو كلينيكالي محتاجين كلينيكالي يعني نيوروفيسيولوجيكالي نبقى قادرين نحكم ان احنا فين بالظبط في البريفرال نيرفز. How many nerve is affected, which function is affected more, means functional diagnosis, sensory, motor, autonomic. Which part of the nerve is affected, meaning is it the axon or the myelin. What is the relevant investigation and the treatments in order to reach an etiological diagnosis, which is a cornerstone in treatment. So as I told before, it is a lower motor neuron character with the general lower motor neuron criteria in the form of muscle wasting, hypotonia, weakness, plus or minus hyporeflexia, and normal or no response plantar reflex. According to the nerve affected, we do have mononeuropathy, in which we only have single nerve trunk is affected, or multiple mononeuropathies, or sometimes called mononeuropathy multiplex, if we do have more than one nerve trunk in the same limb, or if we do have affection of more than one nerve trunks in more than one limbs, it's called polyneuropathy. We have a long list of causes for both conditions, but this type of classifications helps us narrow down the differential diagnosis etiologically. As you see here, this is the list of the causes for mononeuropathy or multiple mononeuropathies. While traumatic is the most common cause of the first, while polyarthritis nodosa is the most common cause of the second. For polyneuropathies, as in most of neurological disorders, we do have heredofamilial disorders in which we have a genetic etiology of the polyneuropathy, and we do have acquired causes. And acquired causes is a long list from infection, toxins, metabolics, endocrinal dysfunction, nutritional deficiencies, vitamins, drugs, autoimmune disorders, as well as paraneoplastic disorders. Pathologically, as you see here, the peripheral nerves has an axon and has a myelin sheath. The myelin is produced by the Schwann cell, and the axon is which is the extension of the cell body. The peripheral nerve function is to convey the impulses from the periphery or from the center and vice versa. So it's either from the upper motor neurons down to the effector organs which is the muscles, or afferent for the sensory information from the periphery up to the CNS. That's why the symptomatology could be related to the periphery or to the central region. In axonal neuropathy, either the axon or the cell body is affected. It will have a peculiar clinical picture. Wasting would be earlier and weakness would be later. And they will be different neurophysiological, we will show later, and the common causes of axonal neuropathy are usually traumatic or ischemic or nutritional or toxic causes. While in demyelinating neuropathy, clinically the muscle weakness occurs early, while the muscle wasting occurs late. And this makes sense because in demyelinating neuropathy, the axons are still there in the first. That's why there is still conduction which keep the muscle state normal until the neuropathic affection becomes more apparent and severe. And they are also different neurophysiologically and etiologically. This demyelinating neuropathy is usually seen with either compression or following infection, especially in autoimmune disorder. Peripheral nerves has three main functions: sensory, motor, and autonomic. Sensation are either superficial or deep, as we know from physiology, and muscle power, as the peripheral nerves convey the motor impulses from the motor area of the brain coming through the upper motor neuron tracts. The peripheral nerves carry these impulses to the muscle in order to convey its action. And we do have the autonomic functions, the involuntary system, by its two components, sympathetic and parasympathetic. Histologically, if we look at the peripheral nerves, we will find them different according to their diameter size. We do have thin fibers and we have large fibers. We do have unmyelinated fibers and we do have myelinated fibers. And even the myelin, either thinly myelinated or largely myelinated. These histological differences has functional importance, where the C and A delta fibers, the thin fibers, are more responsible for pain and tensure function, while the large fibers are more responsible for proprioception and touch when it is sensory, as well as motor fibers. So clinically, patients will come complaining either of motor, sensory, or autonomic functions, and they do have a pattern when it is polyneuropathy, which is bilateral, symmetrical, distal more than proximal, that involves the lower limbs earlier than the upper limbs because the fibers travels longer. If it is multiple mononeuropathy or mononeuropathy, the picture will be a little bit different as regard the bilaterality as well as the symmetry. It would be more unilateral and asymmetrical. If we look at the sensory symptoms, we can see them either from the small fibers, pain, paresthesia, or the large fibers, where we do have global stocking hypoesthesia, as well as deep sensory loss, in which the patient will complain of sensory ataxia. Here the ataxia would be present in absence of the other cranial manifestation characteristic for cerebellar ataxia. The symptoms can be spontaneous and the patient complain of them, or provoked when after pressure, for example, after non-painful stimulus or painful stimulus. The non-painful stimulus produce pain, it's called allodynia, or the painful stimulus produce more pain, which is called hyperalgesia. This is a spinal nerve showing you the different diameters of the fibers. The C fibers, the delta fibers, slower conduction as you see here, while the large myelinated fibers are rapid conductors. The motor manifestation will be reflected in the patient in the form of wasting, weakness, hypotonia, and hypoalexia, while the autonomic manifestation, carried mainly by the small fibers, would be different according to the system affected. In the skin and blood vessels, there will be loss of hair, brittle nails, coldness, cyanosis. GIT would be upper or lower. Cardiovascular symptoms would be in heart rate or blood pressure changes, while genitourinary system could be in increased urine frequency or incontinence or infertility and impotence. So now we are able to diagnose fiber size affection from clinical symptomatology, where the large fiber neuropathy cause more ataxia as well as loss of vibration and proprioception sensation on examination, while small fiber dysfunction cause mainly burning sensation or pinprick on examination, elevating glove and stocking hypoesthesia, in addition to the autonomic nerve fiber involvement and its clinical manifestation. These are examples of patients having sensory neuropathy. These are the most common causes: porphyria, Tangier disease, motor neuropathies, Guillain-Barré, chronic forms of Guillain-Barré, diabetes. These are neuropathies that begins in the arm rather than the leg: diabetes, Guillain-Barré, vasculopathy, multiple neuropathies. These are neuropathies that are more predominantly motor, like acute Guillain-Barré, diphtheria, porphyria, multifocal motor neuropathies. These are predominantly sensory, like pyridoxine, also diabetes. These neuropathies are associated with bulbable hypertrophic nerves, secondary to remyelination. So how to investigate a patient having polyneuropathy? The cornerstone is electromyography and nerve conduction studies. They not only confirm the diagnosis of neuropathy, but helps us differentiate between neuropathy and other lower motor neuron lesion sites. Also, it can differentiate between axonal and demyelinating neuropathy and determine its severity. When we do nerve conduction velocity studies, we know we will have what's called compound muscle action potential, which correlate with the number of motor nerve axons. So when the motor nerve axons are damaged, it will be affected. The same in the sensory. The more fibers damaged, the more affection. Axonal neuropathy, there will be reduced of this CMAB with mild slowing of the conduction velocity with time and prolongation of the distal latency. This only occurs if the fastest and largest axon started to be lost. While in demyelinating neuropathy, the main brunt would be on the conduction velocity. It would be slower than 75% of the lower limit of normal, and the prolongation of distal latency would be marked, not like the axonal form. It would be longer than 130% of the upper limit of normal. Sometimes both are present together. Amplitude changes might happen when we do have secondary axonal loss, or if the patient have what's called conduction block. Conduction block is sometimes seen with local compression. Examples of the neurophysiological finding of conduction block: the amplitude would be low when it is stimulated proximal to the site of demyelination, while it is normal if it is stimulated below the block. Any drop of the amplitude or the area more than 20% can diagnose conduction block. Any increase in the CMAB duration of more than 15% signifies temporal dispersion. Sometimes both are the hallmarks of conduction block secondary to demyelination. We can see that beautifully in this illustration of both median nerve and ulnar nerve. We can see here the amplitude, here the duration of the wave. We can see here the distal stimulation at the wrist. We can see here the proximal stimulation at the axilla and at the elbow, and we can see here the conduction block very beautifully. The same in the ulnar nerve, and we can see the conduction block proximally here. Nerve biopsies are usually needed when the diagnosis is obscure, like in amyloidosis, like in some forms of vasculitis, usually helpful in the multifocal and asymmetrical neuropathies. Sometimes we do also skin biopsy, especially in small fiber neuropathies. We do have also laboratory investigation for screening of the different causes of polyneuropathies. Here we have some examples of the common neuropathies that we see in clinical practice. Diabetes is a very common disease affecting a lot of people worldwide. It can come with sensory motor polyneuropathy. This is the commonest manifestation in insulin-dependent diabetics, in which it is sensory more than motor, and it's small fiber more than large myelinated fibers. That's why we will see the sensory and autonomic neuropathy has the upper hand in the clinical picture. And the pathogenesis is strongly related to the hyperglycemia as well as some oxidative stress happening due to the presence of glucose in the peripheral nerves. It can come with isolated autonomic neuropathies or proximal neuropathy where it affects the nerve roots, or mononeuropathies in which we can also see cranial nerves, and all these manifestations might precede even the diagnosis of diabetes. Diabetic truncal neuropathy in which we do have a radiculopathy affecting single thoracic nerve root. Treatment of diabetic neuropathy start with good control of diabetes in order to decrease the damage produced by hyperglycemia. Then we do have symptomatic treatment for the pain, nerve supplements, improving the blood supply of the peripheral nerves using vasodilators, physiotherapy if we do have muscle weakness, and pancreatic transplantation for improvement of the etiology. Cranial muscular atrophy used to be the most common forms of Charcot-Marie tooth. It is type 1 now because it has several types. It's mainly motor and then becomes sensory, and it has characteristic muscle wasting in the lower limbs called inverted champagne bottle appearance. After affection of the lower limb, there will be hand affection. And we do have other types of Charcot-Marie tooth neuropathies, and the treatment is only supportive physiotherapy and implants. Leprosy is always there, it's never disappeared. It has insidious onset and long incubation period. It has either more profound skin manifestation like the lebromatous type, or more affection of neuropathy like the tuberculoid type. And the treatment is mainly using dapsone and rifampicin. Guillain-Barré syndrome, it is one of the medical emergencies in neurology because it causes ascending paralysis that ends with respiratory failure. That's why good history as well as examination can help save lives. Etiologically, it is post-infectious, which is usually respiratory or gastrointestinal, sometimes seen with tumors or vaccination. This diagram shows the most common clinical pictures in it. It's mainly sensory motor, as you see in most of the cases, while it could be pure motor in 18% or mild sensory. It could be Miller-Fisher, which is severe axonal forms of neuropathy, because Guillain-Barré is usually demyelinating neuropathy. So in here, these are the most commonly involved organisms that the Guillain-Barré starts following them, and these are the antibodies found in the sera of the patients. As I told you, the problem with Guillain-Barré is causing respiratory nerve affection and respiratory failure, which could be fatal in 5% of patients. So the condition starts after initial febrile illness by manifestation in the lower limbs. As a demyelinating neuropathy, it will be motor more than motor in the form of weakness before the muscle wasting. It's rapidly occurring, subacute onset within 3 to 7 days. It will have a full-blown picture. Because of the affection of the nerve roots, it is proximal more than distal, which is different from the rest of the peripheral neuropathies. It's always bilateral and symmetrical. Cranial neuropathy is very common, especially bilateral lower motor neuron facial palsy, bulbar weakness, which precedes the respiratory nervous system affection. Sensory examination usually show global stocking hypoesthesia and papilledema secondary to increased CSF protein, as we told it is autoimmune disorder. The course usually takes 3 to 6 months. With immunotherapy it is less. If it is left alone, it is going to be long. And the treatment is supported by nasogastric tube in patients with bulbar weakness, subcutaneous heparin for unmobile patients, and assisted ventilation for patients with respiratory failure. And specific therapy is plasma exchange as well as IVIG in order to overcome the bad antibodies in the sera of these patients. We need to highlight that corticosteroids is contraindicated in patients with acute Guillain-Barré, as it might be fatal. We do have a chronic form of Guillain-Barré that's completely different in the onset, the course, as well as the treatment, which is called chronic inflammatory demyelinating polyradiculoneuritis. The onset is usually insidious over months, and the course is progressive, symmetrical, proximal and distal weakness of both upper and lower limbs with numbness and paresthesia in the extremes. It's a kind of large fiber neuropathy. That's why sensory ataxia is more predominant in these patients. Cranial neuropathies are common, especially ocular nerves, facial nerves, as well as bulbar nerves. The diagnosis is supported by the CSF increased protein as well as the electrodiagnostic evidence of demyelination. And the prognosis also depends on the etiology. It could be relapsing, steroid sensitive, or it could be chronic and the patient will need immunotherapy every month in a chronic way. In conclusion, we need to know by the end of assessing a patient with neuropathy that is it mononeuropathy, multiple neuropathy, or polyneuropathy? Is it sensory, motor, or mixed? Is it small fiber or large fiber? Is it axonal or demyelinating? And what is the etiological diagnosis in order to have a proper treatment of our patient?